Beat Cancer, the official podcast of the UC Davis Comprehensive Cancer Center. Thanks for joining us today as we have in-depth discussions of the science, research, and advancements taking place at our National Cancer Institute designated Comprehensive Cancer Center. I'm Chris Joyce.
And I'm Stephanie Wynn. We'll also examine proactive approaches to cancer prevention and, most importantly, how we are breaking barriers to beat cancer in our community and beyond. Today, we're talking with licensed clinical social worker and certified sex therapist Jennifer Cooreman. Jena has a special certification in oncology social work with 20 years of experience in mental health and medical social work. She has worked with children, adolescents, and adults in a variety of settings, including regarding our topic today, sexual wellness and cancer. Jena, thank you so much for joining us.
Thank you for having me. I'm really excited to be here today and to be talking about this topic that's really so important.
And tell us why it's so important.
Well, sexual wellness is important because it impacts all of us. It is something that research tells us that about up to 80% of people with cancer are going to experience some type of sexual problem throughout, at some point throughout the trajectory of their treatment and survivorship. So it really impacts a lot more people than we tend to think of. And there's a big gap between how many people it impacts and how many people actually get help for these kinds of things. So there's a lot of folks who are experiencing problems and not getting help.
And why is it so important that they talk about it and get the issue, addressed while they're in treatment?
Well, I think if you back up a little bit, sexual wellness is a part of our overall wellness. Sexual wellness, sexuality is an integral part of being human throughout the whole lifespan. And so if we are interested in attending to our patients' quality of life, we're not doing it if we're not talking about sexual wellness. We're not attending to the full spectrum of quality of life unless we're also attending to sexual quality of life.
We know discussions can sometimes feel taboo. How do you overcome this to have meaningful conversations that are going to benefit our patients?
Well, first I would talk about why is it that these conversations are taboo? Because we know that they are. And I think some of that is just comfort level.
Sure.
And that comes from all directions. We all have varying degrees of comfort in talking about sex and sexuality as individual people in the world, but also as healthcare professionals. So sometimes people coming to us are uncomfortable. Sometimes patients don't know who is the person that I should be talking to. I've had lots of patients come to me and say, I didn't know that this was something that I could be or should be talking to my cancer doctor about. And healthcare professionals, well, we're people too. So sometimes we don't have the comfort level to talk about it. And that comfort level can be related to the topic itself. It could also be related to the person sitting in front of us. So, we all have assumptions. We all have biases. When I say biases, I'm talking about, biases that might be associated with someone's culture or religion or age or sexual orientation or gender identity sitting in front of us. But it also could be related to assumptions that we're making about how important is sex or one's sex life to the person sitting in front of me based on where they are in their cancer journey, how old they are, how I'm relating to them. So, for example, if there is a person sitting in front of me who is the same age as my parents, do I then make assumptions about how important is sex to this person and how comfortable am I asking about sex to someone who may be the same age as my mother or father?
What are some things that you that you say? What are some things that you say to patients, or how do you break the ice when discussing this, so that it does kind of break down those barriers and those walls to make them a little more comfortable, or yourself a little more comfortable?
Right. Well, I think one of the first things that we can do to help people coming to see us feel more comfortable is to first of all just check our biases, check our assumptions. We all have them. That just makes us human. But if we have awareness about what those things are and we're checking those before we're going into any kinds of conversations, we can increase our comfort level by doing some simple things like using the proper words.
Sure.
Now, in healthcare, we're kind of accustomed to this. So this might not seem like rocket science, but using the right words. If I'm going to talk to someone about sex, a great example is if I'm asking you about intimacy, well, what do I mean by intimacy? Do I mean sexual intercourse? Do I mean affectionate touch? It's really important to make sure that we're using the proper words. And then practicing those words. Again, we might not be comfortable asking those words or using those words in conversation. But so practicing that, we can practice with our colleagues, our coworkers, at home, really. And even practicing how we might ask a question. It's okay if it's scripted. And in fact, if it is scripted, the more you say it, the more comfortable you get at saying it. And if you're comfortable with it, then you're going to project comfort. You're going to invite comfort from the person that you're talking to. And actually, I think, healthcare professionals are really good at this with all kinds of other topics, right? We ask people about, their toileting habits. Yeah, we
Bowel
ask
movements
people
and
all
yes.
kinds of uncomfortable stuff. So I think actually we're better at this than we may think we are.
And then, Jena, coming at it from the patient perspective, is this something that you do proactively with all the cancer patients, or do we wait until a cancer patient brings up the topic?
I think that's a great question, and absolutely, we should be asking proactively. If you look at ASCO guidelines, the American Society for Clinical Oncology. I thought I was going to forget that acronym for a sec. But their guidelines recommend that every adult patient be asked about sexual concerns early on in their treatment. So that's not just me saying that. That's ASCO guidelines telling us that that's the best practice. So absolutely, when I see people, that is a part of my initial assessment.
Let's share what types of sexual dysfunction come up during cancer treatment, and then what are some of the ways we can help patients?
First, I think it's important to understand sex and sexuality as a multifaceted issue that resides in a lot of different domains. So I think in the healthcare profession, in the medical world, we are, because of what we do, we're medicine, we are at risk of understanding it in a sort of one-dimensional kind of way, as a physical dysfunction. But sexual problems are not just the absence of sexual wellness is not just the absence of physical dysfunction. There are emotional domains, psychological domains, social, relational domains. And so the problems present in those domains as well. If we start with the physical, because that's often what we call the presenting problem. That's what people are coming and saying is, I'm having problems sustaining or maintaining an erection. I'm having vaginal pain during intercourse. Often that coincides with vaginal dryness. Having difficulties with orgasm or a change in orgasm. Having changes in physical sensation. So our bodies don't feel the same. Sensations on or in our bodies don't feel the same. And there can also be a change in one's sense of sexual desire and sexual arousal. Those are usually the problems that people walk in with. But if you start to scratch the surface of that a little bit more, you're going to find that there's also a lot of indirect things. So those are like the direct physical problems. There's a lot of indirect things that are impacting this as well. Some of those are physical. We can have changes in our anatomy. Some of us have lost organs, lost body parts. We have scarring, ostomies, hair loss, very real physical changes. And those can impact the way we feel about our body, the way we view our bodies. I've often heard people say that when they look in the mirror, their bodies don't look like themselves. They don't recognize their bodies. They may not feel desirable. They may not feel sexy. They may not feel that their partner or potential future partners are going to see them in a desirable way. And of course, that can affect the way, that affects our emotions, that affects the way we relate to other people. We can also be the practical thing of side effects during treatment, right? If you are nauseous, if you are fatigued, if you don't have a lot of energy, if you are going to lots of appointments because you're in the midst of treatment, sex just might not be the highest priority. It might get shoved to a back burner.
And then how do you address these?
I think of all of these changes as kind of existing on a continuum. So, and that continuum being from fixed to changeable. So we've got some problems that are fixed, things that aren't going to go back to what people might call normal precancer, like changes in our anatomy, scarring, lost organs. Those things, we can't put organs back that were removed. So those things are not going to change. We might have things in the middle that maybe there's some room for change. Maybe they'll return to pre-cancer state, or maybe they'll improve but not quite get there. That might be things like neuropathy. That's something that could improve, but sometimes we don't know the degree to which until we just see what happens. But there are other things that are quite changeable or quite flexible, and those are our attitudes towards sex and sexuality, the values and beliefs that we come into around sex and sexuality, our feeling of openness, adaptability, changeability around our behaviors around sex and sexuality. And the interesting thing is that when research that talks to people about these different areas indicates that it is those flexible things, those changeable aspects that make the most impact on one's sense of having a satisfying sex life. So what I mean is that when someone can be flexible, when someone can adapt to changes in the body with behavioral changes, those people tend to report at the highest levels being able to return to a satisfying sex life, something that feels good for them, feels good for their partners, something that they are happy to have in their lives.
Well, we know that obviously a lot of these issues not only affect the patient, but their partners as well. And something that we encourage patients in appointments is to bring a caregiver or somebody that they trust with them, not only to help with just note keeping or the second set of ears to make sure everything is being processed, because there is a lot of information and it's typically very emotional. Also, do you recommend including partners or caregivers in these types of discussions as well?
Yeah. I mean, I think that's really important. I mean, Sex is something that typically we're doing with a partner. So including the partner in that conversation can be a good idea. Of course, that's guided by the person sitting in front of you. But yeah, I think that's a really good idea because communication is something that's really important. And that's something that happens between those two people. There can also be, when a partner becomes a caregiver, that can be a real change in dynamics in that relationship.
Right. Power shift of
A
sorts.
power shift, but also when the person who was my sexual partner now becomes my caregiver, what does that do to the sexual nature of our relationship?
Mm-hmm.
How am I viewed by my partner?
Mm-hmm.
Am I a person who is desirable, or am I the person who they help get dressed? I mean, there can just be a blurring of those two different roles that can be hard to navigate.
You have discussed this topic and presented this topic to larger groups of people, like especially most recently our Pushing Past Cancer event that was geared towards our adolescents and young adults. When you do these types of presentations, are there universal areas that you always touch on just to kind of keep it at a surface general level, or is every presentation different and focusing on something very specific, or what is kind of peeking through in the zeitgeist at the moment?
Well, both, I think. Certainly you brought up the Pushing Past Cancer, which is specific to younger folks, younger adults with cancer who have some very specific kinds of needs. So that might be tailored to a younger audience, but there are definitely some things that are general to the whole cancer population. Some of those things are just one, normalizing and validating the experience of having sexual problems in the first place. So we tend to, I think, relate sexual problems to specific kinds of cancer diagnoses. We tend to think of them in relation to breast cancer, gynecological cancers, prostate cancer. But in reality, sexual problems can show up for any kind of cancer diagnosis. So, and for those folks especially, I think it can be very isolating if you perceive that no one else is having these problems. So we want to just validate, this is, and normalize. This is something that happens a lot. As I said before, up to 80% of people with any type of cancer. I think that's an incredibly high and surprising number. So helping people to feel like you're not alone, and also that your concerns are valid. It's okay and valid to be concerned about sex. I have heard a lot of people tell me that either there was sort of this internal pressure of, oh, well, I have cancer, or I shouldn't be worried about sex. They get that message from themselves. They might get it from other people in their lives, and sometimes they might even be getting it from people on their healthcare team. And we can understand where that comes from, because when you're in the midst of treatment, sometimes sex is put on the back burner, or it does become a lower priority when we're talking about life-saving treatments. But I think inadvertently we run the risk of giving that message that it's not important.
And are there some actual health benefits? Is it going to help the patient, for instance, be more successful, or the treatment more successful for the patient, I should say, if they address any sexual dysfunction, or at least focus on their sexual wellness? I've heard a lot about oxytocin and some of the healing qualities, and oxytocin is something you generate, right, through touch?
Yeah, well, definitely, and I think that's a great question, by the way. Um, there are there are benefits to having sex in general. There are health benefits like lowered anxiety, lowered depression, lowered heart rate. There are emotional benefits, benefits of relational benefits, feeling more connected to our partners, feeling a higher sense of confidence, a higher sense of self esteem. So, definitely benefits to having sex in general. I think, in specific to cancer treatment, addressing these issues can be really important. One, because it contributes to overall quality of life, like I already mentioned, but it can there is a potential for it to impact outcomes in that if someone has experienced sexual side effects related to cancer or cancer treatment, and especially if those problems have not been addressed, there are some articles that suggest that those people are less likely to engage in further treatment if they suspect that they are going to have more sexual side effects.
Oh, wow.
Yeah. So, I mean, and when you think of it through that quality of life lens, it really does make sense, doesn't it? Because we see the same thing in other quality of life questions as well, that, we are often weighing how is this going to impact my quality of life? And I think if it impacts it in a way that is meaningful for me, that informs my decisions.
Before we let you go, I want to maybe instill a little bit of hope, or at least the perspective that a lot of what you're talking about, and correct me if I'm wrong, that a lot of issues are overcomable. That this is not something that will be permanent. We know that some things, especially the physical aspects that you had mentioned before, that are fixed. We can't necessarily overcome those physical limitations. But as far as intimacy goes, as sexual wellness goes, there's a lot that can be done if someone is experiencing any sort of difficulty, correct?
Yes, absolutely. And thank you for pivoting us to the message of hopefulness, because there is lots of hope there. Um, we know that with the proper care, the proper interventions based on a really thorough assessment of this person as an individual, that there are many things that we can do to help people resume a sex life, reclaim their sexuality, and in a way that is pleasurable for them, that is that allows them to have the kind of relationship, whatever that looks like for them, um, that they want in their lives. There's lots of things that we can do, and there's lots of reasons to be hopeful. I think it's important to acknowledge that your sex life might not look like what it looked like pre-cancer. It might not. It might be different. But if we think about other things in our lives through the course of our lives, things many things in our lives change as a result of all kinds of things: getting older, having different ideas, beliefs, values, attitudes change. Our body is impacted by our health as we get older. So it's reasonable to think that our sex lives are also something that is going to change over time. And different doesn't mean bad. Different just means different. And if we can tap into that part of ourselves that is adaptable, that is flexible, that can be open to new things, that's really the best way we can support ourselves in rediscovering, reclaiming a sex life that really feels good for us, that's of our making and something that we want.
Outstanding. Was there anything else that maybe we didn't cover that you feel is important to bring up?
Well, I do want to make a plug for your oncology social worker. So a lot of people ask me, who's the person on my team that I should be talking to? And actually that there's no one specific person. Usually I say, who's the person that you feel most comfortable with? Um, the plug for oncology social worker is this. Social workers, now, while not every oncology social worker might be a sexual wellness expert, what your social worker is expert in is having difficult conversations and knowing how to connect people with the right resources, the right services, point you in the right direction. Social workers also, unlike some of the other healthcare professionals on your team, human sex and sexuality is a really big part of their training. So it might just be that your social worker is the person on your team who's most comfortable in having these kinds of conversations. So if you don't know where to turn, I would advise you to turn to your oncology social worker.
That's excellent advice. Thank you for that. Jena, thanks so much for joining us for this really good discussion because it's not only encouraging, but I think helps to break some of these discomforts as we approach important topics like sexual wellness.
Well, thank you so much again for having me. I really think this is such an important topic, and I'm so glad that you guys are featuring it on the podcast.
Awesome. Well, thank you for tuning in and listening today. If you'd like to get in touch with us, you can email us directly at beatcancer@ucdavis.edu. Beat Cancer is a production of the UC Davis Comprehensive Cancer Center. For more information on our NCI-designated Comprehensive Cancer Center, please visit health.ucdavis.edu/cancer.